Hello, I am Dr. Mirela Cernăianu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Hello there. In this episode, I am going to continue the series on uterine disease. And I'm going to start by prefacing the main conditions that a uterus can suffer from. Number one, adenomyosis, the subject of our first episode on this series. Number two, uterine fibroids, which is the last previous episode. And uterine tumors called sarcomas, that was number three. Number four, and the subject of today's episode, endometrial cavity pathology or disease, consisting of endometrial polyps, endometrial hyperplasia, endometrial scarring, synechia, and last but not least, endometrial cancer. And the last topic will be uterine prolapse. The reason why I started with adenomyosis is because it's a very silent condition that many women suffer from and have no idea. The second episode in the series was dedicated to fibroids, because so many women have fibroids. And as we get older, we are more and more at risk of actually developing fibromatous uteruses that suffer degenerative fibrous changes and are more prone to cause problems for us, especially if we continue hormones after menopause. But the third one, endometrial cavity pathology, today's episode, will focus on polyps and endometrial hyperplasia. And at the end, I'll have a few words about uterine scarring. So I will dive right in and let's start talking about uterine polyps. So first of all, many women have no idea that they have uterine polyps. And I'll talk about symptoms, what they are, how we diagnose them, how we treat them. But keep in mind that uterine polyps are very common. They are abnormal growths that develop on the inner lining of the uterus. That is known as the endometrium. These polyps can range in size from a very small, a few millimeters, no larger than a sesame seed, barely visible, to several centimeters, equivalent to the size of a golf ball, maybe even larger. These polyps are usually non-cancerous. They're benign, though some of them can become cancerous or precancerous. They are not to be confused with the fibroids, because the fibroids develop within the uterine wall. They're fibromuscular in nature, whereas the polyps develop from the endometrium, the lining of the uterus. The polyps grow inside the uterine cavity, always, whereas the fibroids can grow within the uterine wall, but also inside the uterine cavity. The difference is also the fibroids are hard and they're made out of fibromuscular tissue, whereas the polyps are soft and thin and they bleed easily. Fibroids are not very vascular. They do bleed, they make you bleed, but through different mechanisms. Polyps are possibly precancerous, but they're mostly benign, whereas fibroids are almost always benign. So what is the cause of polyps and why they happen? Well, we don't know, but just like all the other uterine pathology I've discussed so far, adenomyosis, uterine fibroids, estrogen is definitely believed to contribute to their development. Most uterine polyps are estrogen sensitive, meaning they grow in response to circulating estrogen. Advanced age is another common factor. So the older the woman is, the more likely the polyps will be. So polyps are more common in women in their 40s and 50s and beyond. They're very rare in young women. There are certain risk factors for polyps. Obesity, hypertension, taking tamoxifen, a drug therapy for breast cancer, genetics seem to have some influence because uterine polyps tend to run in some families. However, more research is needed to unravel the complexities of the precise cause of these uterine polyps. So, first of all, how do you know that you have a uterine polyp? What are the symptoms? Well, some uterine polyps are asymptomatic, meaning they do not cause any noticeable symptoms and might only be discovered during a routine gynecological exam like an ultrasound or looking and investigating other issues. However, when symptoms do happen, they can include irregular menstrual bleeding, heavy menstrual periods, bleeding between menstrual periods, vaginal bleeding after menopause, and infertility. What is the best way to diagnose and detect polyps or growth inside the uterus? Well, the answer is very simple, with a transvaginal ultrasound, a procedure that involves placing an ultrasound probe into the vagina to create images of the uterus, and that is often the first step. Remember, the best time to do an ultrasound is right at the end of the period if you're spontaneously menstruating. The lining inside the uterus will be at its thinnest. So if there is a polyp inside the uterus, the most likely finding on the ultrasound will be a thickening of the uterine lining. Another procedure that's rather rarely used is hysterosonography or saline sonohysterogram, a procedure that involves adding saline into the uterus to make the polyp area more visible on an ultrasound. It might also be used to help clarify the presence of polyps when we see a thickened lining and we're not sure whether it's a hyperplasia or a polyp. It is a rather invasive procedure compared with an ultrasound because the technician or the gynecology physician will have to cannulate the cervix to insert a small tube and inject sterile water into your uterus. It can be rather painful, almost as painful as the next procedure I'll talk about, but the further procedure I'll talk about has the advantage of performing polyp removal, whereas the saline sonohysterogram, the ultrasound with saline, cannot remove any polyp. So it might be painful and it's somewhat invasive and it's simply diagnostic. A more thorough method, and with the possibility of treatment at the same time as diagnosing the polyp, will be hysteroscopy. This is a procedure where we use a tiny camera. When I say tiny, I mean 6mm diameter, so it's very tiny, to visually examine the uterus and to perform an endometrial biopsy. Take a sample of the uterine lining for analysis by the lab. The best thing about the hysteroscopy is that the polyp is clearly visualized and photos can be taken. It can also be removed at the same time, allowing definitive treatment if special instrumentation is available, as the polyps need to be cut at the root and pulled out or removed with a specific instrument called the MyoSure device. Hysteroscopy can be done in the office under mild sedation with oral Xanax or Ativan, avoiding general anesthesia and very expensive facility costs. But sometimes only a polyp biopsy will be possible without having the opportunity to fully remove the polyp. So occasionally a full removal might need to be done in a hospital setting, even after an in-office hysteroscopy. So think of the hysteroscopy as an in-office, moderately uncomfortable procedure, probably less than the worst period you ever had in your life, and lasting about 10 to 30 minutes, depending on the condition of the uterus and the skill of the provider. So you have a uterine polyp, possibly. So now what? How do we treat it? Well, treatment depends on several factors, such as your symptoms, whether you are before and after menopause. It depends on your desire for having children in the future. Bottom line, polyps with no symptoms, so asymptomatic polyps, in a postmenopausal woman might require no treatment. you have the option to monitor the polyp and make sure that it's not growing with a repeat ultrasound in 3 to 6 months, especially if you do not have any hormone replacement therapy, which can unfortunately stimulate further growth of the polyp. So that's a little tricky there. For symptomatic polyps, polyps that bleed, or polyps found in women struggling with fertility, then surgery to remove the polyp, a polypectomy, will be recommended. This procedure for polyp removal can be done with a hysteroscope, exactly what I just mentioned a few minutes ago, and that does not need any incisions or any actual surgery, other than just going inside the uterus, cutting out the polyp with a special instrument, removing it, sending it to pathology. Now, in some cases, medication may be given to manage the symptoms, but that's usually a temporary measure. The symptoms will return as soon as the medication is stopped. This type of medication could be progesterone used 15 days on, 15 days off, could be birth control pills, Depo-Provera shot, all kinds of weird conventional hormone therapies. But again, a repeat ultrasound would always show the polyp is still there, the lining is still thickened at the end of the treatment, and you will likely need to remove your polyp as the symptoms will likely return. Also, women sometimes have no bleeding for a while, and then they have this heavy gush of menstrual flow, and they think, oh, my polyp came out. The polyp did not come out. It just caused more bleeding. So please be aware of the signs and symptoms and be in tune with your body, because I'm going to repeat this until it's very clear. An ounce of prevention is worth a pound of cure. So here's the million-dollar question. Are these polyps, which are rather frequent, are these polyps cancerous? Well, 95 to 99% of the time, no, they're not cancerous, and they're usually considered benign by nature. However, polyps can be cancerous, and a benign polyp that has been growing inside your uterus for years can become cancerous, as the nature of the polyp is a proliferation and growth of cells. So if it's occurring for many years, any growth or proliferation can lead to atypia, which is the first step in becoming cancerous. So please discuss the risk with your doctor and consider not waiting, as polyps are not going to go away on their own in 99.99% of all cases. Now, I know this because I'm a woman. Women are great procrastinators, and they like to wait. I see that a lot in my patients, and as their physician, I believe it's my obligation to inform them of the facts, the findings, the specific condition, but I'm also going to respect their wishes. However, please be aware that if you are offered a procedure to remove the polyp and then you decline it and you want to wait, and it turns out this polyp was more serious and had some cancerous areas in it, now you need a hysterectomy. Well, ultimately, it is your responsibility to make the right choice for you based on your beliefs. But please consider all facts presented here and by your doctor before you choose to just wait and see. Because fibroids do not go away by themselves. They will need to be removed. Lastly, it's very important to mention that regular gynecological exams can facilitate early detection and management of uterine polyps. A proactive approach to health will always yield best outcomes, making a relationship between patient and healthcare provider crucial in managing any uterine pathology, especially uterine polyps. I have seen a fair amount of uterine polyps after menopause in women with no hormone replacement therapy. So after menopause, you still need to see your gynecologist for exams. Please do not see your PCP, your pulmonologist, your primary care doctor. Please ask for a pelvic ultrasound with your annual, maybe every 2 to 3 years, if not every year. So polyps are the third most common pathology. They're pretty frequent, they're easy to diagnose, they're easy to treat, and they're almost always benign. So with this, let's move on and talk endometrial hyperplasia. What is endometrial hyperplasia? Well, I talked a little bit about this condition in my estrogen excess episodes, but many women have no idea what it is, though it could be an endometrial cancer precursor. So let's talk about this for a little while, as it is a very important condition. It is the first warning we will receive, both you, the patient, and me, the doctor, that there is something wrong and off balance with your estrogen, and that you are suffering from estrogen dominance or unopposed estrogen effect on your uterine lining. So let's talk more about that. The uterine lining is the special mucosa that exists only inside the uterus. And it is special because it is there to allow for implantation of a baby and development of a baby for 9 months. And it will suffer significant cyclical changes that happen ideally the same way every month for many decades, with the single purpose of fertility and baby making. I described the uterine lining in a previous episode as a plush mucosa, similar to a nice, soft, velvety carpet, where the fertilized embryo could burrow day 7 after ovulation. Imagine this carpet as being possibly very, very, very thin. This is what happens at menopause when there's no longer growth of the lining at all. On the other hand, let's imagine this mucosa as a plush, soft, comfortable bedroom-type carpet that's perfect for the baby to burrow its way in and grow the placenta into it. Now, we went from thin to normal. Let's go to thick. Imagine an abnormally thick carpet where you can easily lose everything because it's so deep. It's also hard to clean. There are deep spaces where dirt and dust collect and sit, festering and breeding all kinds of things. That's not pretty, and that's not what we want, right? But this is what endometrial hyperplasia represents for your health. Now, the bacteria and the dust festering is a metaphor for your imagination. In reality, there is no bacteria inside the uterus, but the crevices, the deep pockets of the uterine lining with hyperplasia could be breeding ground for cancer. So let me explain the medical terms hyper and hypo. Hyper means excessive and overgrowth, more growth than what is normal. Hypo means lack of growth or minimal, less growth than what is expected and less than normal. Plasia, it's a term used to describe the growth process. So hyperplasia equals excessive growth. Hypoplasia is poor growth of a tissue. So hyperplasia of endometrium is simply an excessive growth of the uterine lining beyond what is expected and what is considered normal. Let's talk about types of endometrial hyperplasia. There are quite a few, actually 4 of them, and you need to know them because their risk of cancer and the subsequent treatment for each one of them can be very different. There are 4 types of endometrial hyperplasia. Then it's not that complicated to remember. I'm going to break them down very simply for you. There's simple hyperplasia, complex hyperplasia, and each one of these 2 can be with or without atypia. So let's chat very quickly about each one of them. Let's start with the least likely to be a problem. Simple hyperplasia with no atypia. The most common, the least likely risk of cancer, 1% or less. Next is complex endometrial hyperplasia with no atypia. It carries a low risk of cancer, about 3%. It is more significant and a significantly higher degree of severity above simple hyperplasia, but not that severe and not that common. Simple hyperplasia with atypia carries about 8 to 10% risk of cancer. It's a more serious condition. And last but not least, complex endometrial hyperplasia with atypia is technically a cancer precursor and carries a 30% risk of cancer. It is treated very seriously, and hysterectomy is a treatment recommendation that is standard of care for such an advanced process of abnormal proliferation. Now, why do you need to know about all of these types of endometrial hyperplasia? Well, because endometrial hyperplasia can lead to cancer, but mainly because it is a clear indicator of estrogen dominance and unopposed estrogen, which is a serious hormonal imbalance. Most instances of endometrial hyperplasia, probably 90 to 95% of them, are always the simple hyperplasia with no atypia. Occasionally, we might see complex hyperplasia with no atypia. Very rarely we find hyperplasia, whether simple or complex, with atypia. Many women panic when their doctor explains you have simple endometrial hyperplasia with no atypia. They hear the word hyperplasia and they think, oh my God, I got cancer. If you panic, it means there's not a clear communication of what this is and why it's happening. But this condition, the endometrial hyperplasia, simple with no atypia, is the most responsive to medical treatment, which is addressing excess estrogen. So let's talk about why too much estrogen and how hyperplasia of the uterus can actually happen. In quite a few previous episodes, I talked about the cyclic growth of the uterine lining, and I explained how during your menstrual cycle, the first 2 weeks, the lining grows under the influence of estrogen. Then the ovulation happens, and your ovary will now make progesterone, which is a crucial fertility and estrogen balancing hormone. This hormone, progesterone, will stabilize your uterine lining, will make it implantation ready, and stop it from growing further. It is like any other checks and balances process. If not balanced properly, the estrogen influence on your uterine lining will run amok and cause problems. Many women do not ovulate, and they are unaware of it, as they can actually have a monthly period even in the absence of ovulation. Without ovulation, you are making purely estrogen only. There is no progesterone. So there will be no hormone to check and counterbalance the growth effect of estrogen on your lining. So your lining will keep growing until it outgrows its blood supply and will start bleeding and shedding. This process, if it happens month after month at about 28 to 30 to 32 days, it will give you the false sense of, oh, I'm regular, I'm ovulating, I'm having a period. But if it happens year after year, it will lead to endometrial hyperplasia. So I did a quick recap here on how the cycle happens for you to understand why estrogen and progesterone balance is important. So coming back to endometrial hyperplasia, how do we diagnose it? How do you know that you have it? Well, simply put, you will likely experience some form of abnormal bleeding. All right, so your next question should be, all right, doc, well, how do I know when my vaginal bleeding is abnormal? Well, then let's clearly establish what is normal vaginal bleeding right here, right now. A regular period that occurs every 26 to 30 days, that's always predictable, comes when you expect it, lasts 4 to 6 days, is average in flow, 3 to 4 pads or tampons per 24-hour day. That is normal, period. So by definition, abnormal is everything else that's not included in here. So what type of bleeding you need to report to your doctor? Again, anything other than what I just described a few seconds ago is abnormal. But let me be more specific. Abnormal is long periods, 7 days or more. Abnormal is short periods, 1 to 2 days. Abnormal is super heavy flow with max pads or max tampons needing to be changed every few hours and more than 5 or 6 a day. Abnormal is a light flow where you barely need to use a pad. Abnormal are short cycles, 25 days or less. Abnormal are long cycles, over 35 days. And last but not least, abnormal is erratic flow from one period to the other. You have a light period 1 month, heavy period another month. And abnormal is an erratic cycle length from 1 month to the other. Like 25 days 1 month, 35 days another month, so on and so forth. All of these situations are abnormal. They're not normal. Again, normal is very clear. Your period is always predictable, 26 to 30 days just about, It lasts 4 to 6 days, average flow, and that's a normal period, normal vaginal bleeding. I also want to talk here for a second and be very clear that any vaginal bleeding after 1 year of no spontaneous menses equals postmenopausal bleeding. That is not a period. It does not mean, oh, I got my period back. I wonder what happened. That is not a period. Please do not delay care thinking, well, it was just a few hours. It was just a few days. It must be okay. It stopped on its own. It must be okay. Well, it happened last year and it never came back until 3 months ago. I thought it was normal. It must be okay, right? I literally heard all kinds of rationalizations that led to delays in care. Please remember, if you are not on any hormones, you are at menopause. Any bleeding after menopause is abnormal. Your body is giving you a sign something is wrong. You need to see a doctor as soon as possible. You need an ultrasound, and you need an endometrial biopsy or a hysteroscopy. What about if you're on hormones? Can you bleed on hormones? Well, I had about 3 episodes of that, so just go back a few episodes. There's lots of information about that. But let me recap this very shortly and briefly in this episode for you. You have 2 options if you're at menopause on hormones. You either have chosen to use progesterone 10 days a month, which means you are allowing your uterine lining to shed once a month, allowing for a possible period. I say possible because if the amount of estrogen provided by the hormone replacement therapy is not sufficient to create a lining growth and proliferation, so your estrogen is too low, then there is nothing for the progesterone to stabilize, or not much, and you will not experience vaginal bleeding at the end of the progesterone. So that's not always something that happens, but if you have enough estrogen, your progesterone taken 10 days, 15 days every month will make you bleed. And it's not the progesterone that makes you bleed, it's the estrogen. I talked about that in the previous episodes. Please go revisit those. Lots of information. Option number 2, you have chosen to use progesterone daily, which means you should not have any vaginal bleeding. It is important for you to know that bleeding vaginally when you take progesterone daily and use any form of estrogen, it doesn't matter whether it's the daily cream, the patch, the daily gel, the pellet, you should not bleed at all. Again, go back and listen to those 3 episodes about the bleeding at menopause, with hormones, without hormones. I just wanted to make it clear because many women seem confused. And for some reason, many women are very accepting of abnormal vaginal bleeding and do not understand that any bleeding outside of the norm needs to be discussed with a doctor. It means you likely have a hormonal imbalance, whether it's your own hormones that your body's making, or it's because the hormones introduced in the form of replacement are not interacting well with your uterus, or maybe they're not being balanced optimally for you. It's all a sign and a warning that needs to be discussed with your doctor. Please do not wait till the next visit when you need a refill to mention that you're bleeding. Need to set up an appointment, be evaluated, so that way adjustments in your hormone replacement therapy can be made to ensure that the hormone replacement therapy is safe for you. Coming back to the endometrial hyperplasia. How is endometrial hyperplasia diagnosed? Very easily and very simply, with an in-office procedure called endometrial biopsy. This is a very small and very thin tube with a few openings at the top and an introducer inside that's being pulled to create suction through those little openings. So this will aspirate uterine lining tissue inside the tube. Then the doctor will take it out, will place the aspirated tissue into a formalin cup, do a few passes to collect enough tissue. Literally, it's a procedure that lasts under 5 minutes. The procedure itself is not very painful, but when the suction is activated, it can cause a little cramping. When the thin tube touches the uterine fundus at the top of the uterus, that can be felt as a very slight uncomfortable sensation. However, the worst part in some women is not the procedure itself, but it's actually the procedure of dilating the cervix. that barrel-shaped structure sitting at the uterine entrance. Now, rest assured, we have medication to help soften the cervix, allowing for a comfortable endometrial biopsy even in advanced cases of cervical stenosis. Now, one single dose of misoprostol, which is the softening medication, will not work in severe cases. You will need to have your cervix softened and ripened maybe 2, 3, or even 4 days before the procedure. That depends on each case. So please make sure your doctor is well-versed in assessing how severe the stenosis is to make this procedure what it actually is: simple, easy, under 5 minutes. Now, in the old days, a woman would need to go to the operating room and be placed under anesthesia and have a DNC performed, dilatation and curettage. This procedure is now done in the doctor's office with no anesthesia required. Again, as long as the cervix has been prepped correctly, and it should be under 5 to 10 minutes, very easily tolerated. So I talked about endometrial hyperplasia. I talked about the different types, the signs, the symptoms, bleeding, and how endometrial hyperplasia is diagnosed. And last but not least, let's talk about treatment. In order to treat endometrial hyperplasia effectively, we will need to consider the cause and address it at the same time as treating the hyperplasia. The standard of care treatment for hyperplasia is high-dose progesterone therapy or progestin therapy. Some doctors still use progestin therapy and not progesterone, and that's not necessarily wrong or right, but a progestin is a progesterone receptor disruptor, even though it is very effective in annihilating the excess growth tendency or the hyperplastic tendency of the uterine lining driven by the unbalanced, unchecked estrogen. There might be more side effects with the use of a progestin versus progesterone. The treatment should last a minimum of 6 months, maybe 12 months, and the woman needs to receive minimum 15 days of progesterone or progestin therapy monthly. At the end of the 6 months, another endometrial biopsy should be performed to ensure a resolution of endometrial hyperplasia. An intrauterine device like Mirena IUD can also be used to effectively treat simple hyperplasia with no atypia. It might be significantly harder to confirm with a biopsy the resolution of hyperplasia if you have an IUD already inside the uterus, because performing an endometrial biopsy while there is an IUD inside might be challenging and much more uncomfortable for the patient. The chance of complete resolution of endometrial hyperplasia with either the Mirena IUD or an oral progesterone or progestin is very high. However, the rate of reoccurrence of hyperplasia is estimated to be as high as 40% or more in a study done in Norway, where the participating women were followed and sampled again 2 years after their treatment. This makes sense because if we do nothing to address what led to the hyperplasia in the first place, it will most likely come back. So please be aware that estrogen dominance will have to be addressed successfully in order for endometrial hyperplasia to be cured once the treatment is discontinued. I keep coming back to estrogen dominance and unopposed estrogen as being the key factor in so many uterine pathologies and diseases. As a matter of fact, it is the leading contributing factor or direct cause for every single pathology that I have discussed in this episode and the previous 2 episodes for adenomyosis, uterine fibroids, uterine polyps, endometrial hyperplasia. If you are a woman between the age of 15 and 55 and you're still menstruating, please consider checking your estrogen and progesterone balance every year with your gynecologist. Please pick and select the gynecologist who understands hormones and how to test them. And if you want more information about when and how to get your hormones checked, there's plenty of information provided in previous episodes where I talk about estrogen and progesterone. So please go back and listen to those. There's lots of information there. Before I close, let me say a few words about uterine lining scarring called synechia. This is very rare and it's most frequently likely to happen after an aggressive uterine curettage done with a metal sharp curette that simply takes too much tissue all the way down to the myometrium, not allowing any growth of a uterine lining in that specific area. This is mainly important for women who are trying to conceive and have a history of a uterine procedure. This is usually diagnosed with a hysteroscopy, placing a small camera inside the uterus and examining the quality of the uterine lining. A very thinned out and scarred area can be easily identified with the camera, can be debrided with an instrument or usually sharp scissors, followed immediately after by an intense high-dose estrogen protocol to allow regrowth of the endometrium in that area. This is reasonably easy to do, and any gynecologist should be able to suspect, diagnose, and help resolve such a rare condition. I will end here and we'll pick up the series of uterine pathology with the next episode when I'll talk about uterine cancer. Thank you for listening. If you liked the information you heard and you'd like to hear more, please subscribe and follow my podcast. Should you find the content helpful to not just you, but possibly others, please share it and feel free to leave us a review. You are welcome to join the Facebook group, The Warrior Optimizing Wellness MD. I certainly hope that you've heard many things in this podcast that made you go, wow, I did not know that, or wow, I'd like to know more. So keep listening and I'll keep talking.